everyone. So I'll be talking about SALK now.
Can we have the attention, please?
LKs are currently the preferred mode of management of any forms of partial corneal opacification. However, we encounter a lot of graft failures on account of suture-related infections. And SALK or suture-related, the term is used interchangeably, either call it superficial or sutureless. Either way, this can be used for a host of conditions, including degenerations, basement membrane, and some forms of stromal dystrophies, and anterior corneal scars secondary to infections or trauma. Now, it's important to know where this surgery fits into the whole spectrum of lamellar procedures. So if you have a patient of partial corneal opacification, we need to address the depth of the opacity. So very superficial opacities less than about 100 microns would do well with PTK. As you start going deeper and deeper, PTK becomes less of an option because of the high hyperopic shift induced by PTKs. So depending on the depth, you could do an ALTK, LK, deep lamellar keratoplasty, and then finally DALK, where you just leave the stroma and the endothelium. So SALK fits somewhere in between PTK and ALTK, where PTK would be too less to remove the opacity and ALTK would be an overkill. You can do it both with the microkeratome system or the laser system. At RP Center, we are using the Moria microkeratome system to harvest the graft. If you have done LASIK using these microkeratomes, then it is just in the same way. The host is also cut in a similar fashion. You apply the micro suction ring on the host side and run the microkeratome. You get blades in different sizes, and generally we go up to 200 microns or less, because anything more than 200 microns you would need sutures to apply the graft. Following this, the host bed is dried, and as you would put back a free LASIK flap, you apply the graft. Generally, you might see some ovalization in the graft, so one can orient the graft on the ovalized part of the host and try to adjust it accordingly. And then you use a couple of Mirocell sponges to draw out the fluid using capillary action from the interface. And as you'll find that as you draw out more and more fluid, the graft will tend to stick on the cornea, and the glue is applied on the edges of the graft. Post-operatively, bandage contact lens is kept for 6 weeks. Antibiotics for 6 weeks, steroids initially a little frequently, and then tapered over an year, and preservative-free lubricants. These are a few examples of this surgery performed in various conditions. So as you can see that the graft generally clears up quite nicely after 6 weeks of surgery. Now this surgery can also be quite easily combined with the phaco if the patient has coexisting cataract. So what you do is that after you harvest the graft, you get a clear bed of the cornea. So at this point, you hold on to the graft, and you have just removed the host. The phaco resumes as in a normal case. And once you have done that, the only difference in these cases is that I like to put some air in the anterior chamber to have a taut host cornea. And I also like to apply a couple of sutures on the host cornea to have a very tight anterior chamber, and then these subsequent cases similar in nature. These are a couple of patients who underwent this surgery, the triple procedure with SALK. Now, a major issue with SALK is graft sizing, especially when you're using a microkeratome. So you would encounter two scenarios. Either the graft is too big or too small. If you have a larger graft, it's quite easy to handle. You measure the graft, you measure the host size, and you keeping a 0.25 millimeter oversizing, you cut the graft, punch the graft again with a trephine, and remove the peripheral rim, and then you can apply the recut graft accordingly. The more trickier problem was how to manage if you have a smaller graft. Now the one option was that you have a backup eye and you cut a fresh graft, but generally if that machine on that particular day has cut say an 8.5 graft, it will again cut the similar graft even if you try to vary the pressure. So now what we have resorted to is, because we were getting a lot of smaller grafts, so what we do is we measure the size of the graft which has actually been cut and the cut which we wanted, and we add about, we subtract about 2.5 from that, and then we use the host cornea which was already been cut. Now these are corneas which are having degenerations or dystrophies, so as such there is no active disease process in them like an infection. And then what you get is a small rim, concentric rim of the cornea which you can apply in the defect which was left. I generally prefer to apply this concentric shaped host cornea, the part of the host cornea in the superior area which would be well covered by the lid, and then subsequently glue is applied. So this is a patient who had to undergo this technique. As you can see, on first post-operative day, the concentric graft is quite highlighted, and within a few months it merges quite well as its patient's own cornea. So we published these results a few years back in Cornea, and the take home from these results was that the patients recover vision very fast following this surgery, even if it is a plain SALK or SALK with phaco. So compared to a procedure like DALK or ALTK, where it takes about 6 months to 1 year to regain vision, in these cases the final visual acuity you almost reach by 6 weeks of surgery. The complications which you can expect in these cases are epithelial rejection, which we have seen, recurrence of pathology, especially things like granular dystrophies, they come back, and we haven't encountered any cases of graft infection as yet. To conclude, it's an effective technique for management of anterior corneal opacities. Its indication is where PTK is inadequate to treat the pathology, but rest of the suture-based surgeries are an overkill. It has a very short learning curve compared to some other lamellar surgery techniques. There is a much faster visual acuity recovery with a lower risk of graft infection because of absence of sutures. When combined with phacoemulsification, it greatly improves the visualization for the surgeon during the surgery. A couple of limitations: the best corrected visual acuity generally stops at around 612. Then there is an added cost of the keratom machine and the fibrin glue. Thank you.
Thank you, sir. Sir, a few questions. Is there any choice of patients like you select other than the depth of the scar, depth of the lesion? Is there any choice like deep set eyes or something which you exclude for?
So in extremely, the Moria keratom is an Asian model. So as such, it's designed for slightly smaller apertures. There are some other videos which I have, for lack of time, I didn't show. So if you have a smaller aperture or a very tight aperture, you can reverse the orientation from medial to lateral, and then it gives you a little more space. Then another trick is that when you block that patient, these are done under block. So don't use hylays in the mixture of the xylocaine mixture. So that will impede the dissipation of the xylocaine, and it sort of slightly gives you a couple of millimeters extra, which is all you need. So barring one case which I remember, which we just could not, the orbit was completely devoid of any fat, and it was just bone on which the spectrum was applied. That was one case where we couldn't proceed with the host cut. Barring that, I haven't had any instance where we had to sort of abandon the surgery because of the small aperture.
Okay, thank you, sir. Are there any questions from the audience? Okay, if not, we'll proceed to the